Hey everyone, welcome to week 5 of the Psych Elective. I hope you guys are enjoying the beautiful weather, although a little hot and muggy. Um, I just want to give you an overview of what you'll be doing this week, as well as kind of comment on last week's discussion boards. So we're going to start with commenting on the discussion boards last week. So the first topic I had you guys go over and kind of learn more about was the role of potential psychedelics and hallucinogens making a comeback as potential treatment for mental health conditions. Your discussion boards were really great. Overwhelmingly, you all seem to agree that there is a potential use for hallucinogens in psychiatry. However, you guys also raised the caveat that there's still a lot of research that needs to be done, and that studies that have been done and have shown some positive effects in treatment tend to have smaller sample sizes. There's not a lot of randomized controlled trials. They're open label. There's very specific inclusion-exclusion criteria that might not apply to the general public, so the external validity might be low. You also mentioned that this kind of treatment with psychedelics would have to be done in a very controlled setting. And I think that's an important point, and you're absolutely right, especially with, for instance, MDMA and PTSD. Those sessions are all-day sessions for patients, and they have to have a specialized room that they're in with equipment and specialized and trained medical staff, nurses, and they're with the patient. So wondering about that with all of it, it's very resource intensive. So what is the feasibility of actually being able to use this in practice? Do we have space to create rooms like this, resources to be able to carry this out? What kind of setting do we need? And then additional training, and the costs that go with that. So there's some feasibility issues too. What about people that live in rural areas? Would they have access to it in remote areas? The types of people that would benefit from these treatments. So a couple of you had brought up like a lot of these patients who they've tried this in are treatment resistant. So they've tried multiple medications and therapies, but nothing has really worked for them. So what patients would be eligible for something like this or not? And then I agree with you that there is a potential for medicinal use. However, I think it's important for us to always ask the question with any medication or drug, what is it exactly we're trying to treat? So are we trying to treat symptoms of the condition in the short term? Long term? Are we trying to get to remission? Are we trying to get at the underlying mechanism that's contributing to the pathophysiology? So, even if somebody taking LSD or psilocybin makes someone feel less anxious, how is that any different from drinking alcohol? When used in combination with therapy, that's where you could say this could be a difference in that it's actually aiding in the therapy. And a lot of the stuff that you read about with MDMA and some of you commented was that it opens the patient's mind, allows them to connect with their trauma. And so as a biological neuroscientist, I don't know what that means exactly. So what is that drug doing in the patient's brain to allow them to connect with their trauma? And unfortunately, the thing that these trials don't tell us exactly is what's happening. It's still a black box. And I'm not sure how many of you are familiar, but the FDA doesn't require proof of mechanism of action for new drugs. So it just needs to show that it is capable of significantly reducing symptoms, so clinical symptoms, but not really concerned so much in how it's doing that. And remember, I had brought up before that with treatments for PTSD, while, for instance, some treatments might generally be effective at significantly reducing symptoms, they're not getting to a subclinical point. So are people getting subclinical, no longer meeting diagnostic criteria? For the FDA, it just needs to be a significant decrease for new drug approval. Okay. And the other thing is that the trials that have been published generally show positive findings. So I want you to think about how many trials didn't have positive findings and were not published. Who is sponsoring and publishing these trials? So, for instance, the MDMA trials in PTSD are largely sponsored and published by MAPS, which is a group that has an invested interest in this working and being successful. So those are just kind of a couple of things I want you to think about. Just playing some devil's advocate. Also, I thought you guys brought up some really good points about even if these these hallucinogens had some side effects, are they really any worse than current side effects for other, like let's say antidepressants? SSRIs was something that was brought up. So you guys had some really great responses. And then I think you're right that there's a need for new treatments and new ways of targeting treatment-resistant disorders. And what we currently have isn't cutting it. So we do have to take other avenues. And there is a potential, promising avenue for looking at hallucinogens or other types of pharmacological agents. For your second discussion board, we discussed first generation versus second generation antipsychotics. And the topic that this was related to is the drug-induced movement disorders. And so this is a major issue, especially with these antipsychotics. So for the majority, everybody kind of had said, I would lean towards second generation versus first generation antipsychotics. And I think your arguments for it having less movement-related side effects and for second generation being well taken and kind of well accepted and lower side effects there, that I think those points are really good. But you also mentioned that the second generation antipsychotics aren't without their own side effects. So there's concerns about metabolic side effects, and several of you even pointed out that the efficacy between a first generation and second generation antipsychotic really is no different, that they have similar efficacy, but when it comes down to their side effect profiles, that's where they differ. So when first generation is going to be the movement related side effects, your second generation is going to be a metabolic side effect. And, depending on the patient, you might decide whether or not to go with a first or second generation, depending on patient-specific factors. So for instance, if you had a patient who was elderly and there was a high risk of falls, perhaps a first-generation antipsychotic wouldn't be the best idea. But on the other hand, if you had a patient that was diabetic or overweight, then perhaps a second-generation antipsychotic would not be a good idea. So you guys had very thoughtful responses to the second discussion post as well. And I really appreciate, and I can't stress enough how much I appreciate the effort you're putting into your responses across all of these weeks so far. And also including references and really kind of looking more into the literature. So I kind of hope you enjoyed learning about some of these, different conditions, drug-induced movement disorders that really does plague psychiatry and mental health treatment, especially with antipsychotics. Maybe you got a chance to practice the Ames assessment. You probably will come across this and have to administer this assessment, even in just general practice, even if you don't go into psychiatric pharmacy. So it's a pretty common assessment tool. So I gave you a couple of those there. This week is exciting. We've got a new topic. It's going to be about psychotropic use during pregnancy and breastfeeding. So I've included a really nice systematic review about prescribed psychotropics during pregnancy. Pregnancy, neonatal, childhood outcomes. It's a little bit longer, but it's very thorough, and I think it's kind of a good overview of everything. I've also included a podcast. It's an interview with a woman and a woman doctor who describes a case with a patient who is pregnant and her approach to treatment with that patient. And then there's some discussion about the risk-benefit ratio of psychotropic use during pregnancy. I've also included the guidelines for psychotropics in pregnancy. This is just for your reference, so you don't have to read it, but it's good to have guidelines on hand in case you're interested and as a resource. Interestingly, these guidelines have not really been recently updated, so just keep that in mind. There is a discussion board that's called "To continue Paxil during pregnancy or not? That is the question." So I'm posing a patient case of a woman who's pregnant and is currently on Paxil, and her doctor is not sure if they want to continue her on Paxil because of potential risk to the baby. But the patient is concerned about her own symptoms coming back and so forth. So it's basically up to you guys to argue for and against the use of continued Paxil use. I've divided you guys up into a for or pro stance and a con or against the use of Paxil continuation. Your names are listed under which argument you've been assigned to. So you're going to provide an argument on your, whether or not, for whatever side you're on. You don't have to respond to any classmates' responses, but please read each other's responses. You are more than welcome to respond to each other, have some discussions, but it's not a requirement for this week's discussion board. So the next thing that we have going on is our second live session. So our second live session this Friday at 12:30 is with a psychiatric panel. It's going to be on Zoom. The link is also under the modules, and I'll send an announcement just as a reminder. There are 3 panelists, and they're all pharmacists, but they've have different areas of expertise in the realm of psychiatry. So one of them is an associate professor from our department, Dr. Burkhart, and he studies a lot of pharmacoepigenetics, insulin resistance, metabolomics. So he's going to talk to you about his perspective coming from a researcher in psychiatric pharmacy. Then we have Dr. Sarah Goldsboro, who is a pharmacist, and she is a clinical pharmacy specialist in psychiatry at Beaumont Health. She works in inpatient psychiatry unit. She's board certified in psychiatric pharmacy, and her areas of interest include transitions of care, schizophrenia, patient education, and major depressive disorder. Then our final panelist is a professor, and he is very interested in psychotropic therapeutics, psychedelics, suicide prevention. So it might be kind of a good opportunity for you to talk to somebody that has that interest in psychedelics. So I have a post that has their bios included there. Oh, I'm sorry. The third panelist is Dr. Crismano. So it has their bios, and so take a look at those. And then what you're going to do is I want you to submit one question, at least one question that you have for the panelists. Please have this submitted by this Friday at noon. So I have at least a half hour to gather the questions together for the panelists. You can pose it to the entire panel, or you can pose it to a specific panelist if you'd like. But just at least one question that you'd like the panelists to answer, and anything, just so we have something prepared so we're not sitting there staring at each other. So if you have any questions about the assignments for this week, just let me know. You will be writing a reflection, kind of just another one of those reflections based on the psychiatric panel, similar to what you did with the student wellness session with Patty Dixon. And both your discussion board and your reflection assignment are due next Wednesday by 11:59 p.m. Again, I apologize for not having this stuff released sooner. I am currently getting ready to undergo surgery. So I was recently diagnosed with triple-negative breast cancer, and I'm having a bilateral mastectomy next Wednesday. So I've been kind of preparing works-related stuff, course-related things, my home, my kids, and everything in preparation for that. So I was a little behind this week. So you have an extra day. Next week, the material should be released by 12:30 on Wednesday. I'll comment and give summary based on anything that has been posted by Tuesday at 11:59. So with that, my next couple videos I might look a little different in. I might be looking a little groggy or whatnot, and I thought it was important that I let you know what is going on. So I will keep you guys posted, but I look forward to seeing you guys on Friday. Let's try to put our cameras on if we can, if it's possible for you, so the panelists can see you guys and we can have more kind of face-to-face discussion. If you have any questions about anything, just let me know. Shoot me an email. Yeah, I look forward to seeing you guys. That's the other reason why my hair is blue, is I'm dyeing it all sorts of colors before I go through chemotherapy and it's my hair, which my kids are excited that they get to cut my hair and shave my head for me. I've allowed them to do that. So, fortunately, this course will be done before then, so you won't see me with a shaved head probably. All right, so I will see you guys Friday. Take care.